I'm Dr. Suresh Nair, part of the Education Committee as part of the Aspire organization. I'm practicing at the Seed of Life Fertility Center and Women Cares Medical Center in Singapore. And today I'm honored to have an opportunity to moderate this really exciting area, progesterone-primed ovarian stimulation. In the last recent years, this has gained a lot of interest and traction, and people are quite excited about it because it is something that is easy to adopt. And over years, experts have spoken about this area and said that this has become a fairly easy to embark on stimulation protocol, and yet cost effective, and yet giving us good outcomes. Now, I just want to say that in our stimulation protocols, we know that one of the biggest issues has been to sort of schedule our cycles in order to fit certain sort of arrangements with the patients and also in our clinics as well. Now, is the PPOS, which stands for progesterone-primed ovarian stimulation, which is more cost-effective, be able to fulfill the gaps that has been laid by the antagonist protocols? Are they the same outcomes? And is it going to be useful in certain circumstances, like where we don't know when we can start the cycle? Can we have adjustable cycles as well, or start points? In order to answer some of these really pertinent questions and issues, we have none other than Dr. Jason Yenping Ho, a renowned expert in ART, who over the 2 decades of experience he's had in his practice at the Taipei Fertility Center, has led the field of reproductive medicine in his center. And I had the privilege of meeting Jason in his center, and I'm totally impressed by the amazing progress that you made. And I think, Jason, you've were involved in ART in the early years as well, even before the antagonist protocol had been part of routine practice. So I just want to ask you, Dr. Jason, what are your points of view in regards to this new intervention, fairly new because it's had a recent introduction, maybe in the last 5 years or so? What is progestin-primed ovarian stimulation? How does it really work physiologically? And how is it different from the antagonist protocols?
Yes, Professor Nair, thank you for inviting me in this iPod podcast program. And I'm very glad to share my experience in the progestin-primed ovarian stimulation protocol. Because as you said that this PPOS protocol is very convenient and is now almost applied in every ART centers. The beginning of the progestin-primed ovarian stimulation protocol arises from Dr. Huang Yanping from Shanghai Jiao Tong University in China. They proposed the idea that they can use the progestin to double stimulate the protocol. Their first paper published in 2014, and it says that you can continue your stimulation into the luteal phase of the cycle, because our training tells us that we should start with cycle from the beginning of the menstruation start, usually in day 2 or day 3, and start a follicular phase stimulation. And in this way, we apply the GnRH agonist or antagonist. These two medicines, the major effect of agonist or antagonist is to prevent the LH surge, so that when we start to stimulate the follicles, we have no fear of rupture of follicle in LH surge. So we use agonist or antagonist in this. And because a couple of years ago, physiologist has also find that actually the progesterone can also suppress the LH surge.
Yes.
Yes, but none of us use this in our daily practice until the so-called double stimulation was applied, because they stimulate the follicle in the luteal phase. And they found that in luteal phase, with the nature elevation of progesterone, it can also suppress the LH surge, so that they can also take the follicle, puncture the follicle, and get the egg from the luteal phase stimulation. And also in that years, in those years, random start was also noticed that we can start with stimulation anytime, but in that circumstances, they use antagonist to prevent LH surge. But actually, when we apply the double stimulation, we found that actually the progesterone or progestin also suppress the LH surge. So if we want to use random start as our protocol, we can also use progestin to prevent LH surge. So this is the basic concept that the progestin-primed ovarian stimulation can be used in stimulation cycle, because the progestin actually can suppress the LH surge.
So may I ask, therefore, if you were to make comparative studies, there are a lot of comparative studies that have been done. Antagonists, long agonists, the short agonists, and Dr. Atabi's paper had made comparisons, and his proposition, or rather his conclusion, was they're fairly similar in their outcomes. But he made this comment that, if I don't mind, I will just read up from his paper. He said when it came to the gonadotrophin assumption and oocyte yield, this was similar when progestins or GnRH analogues antagonists were used. But then he used far less, the progestins were associated with far less gonadotropin consumption compared to the long agonists protocol. And this we understand that because, we have always known that long agonist is suppressive, So what are your points of view? Because this is a really fundamental thing, because one of the biggest problems we are facing in our scheduling cycles, and especially now that we have women who want to come for egg freezing, they are a different category of, if I might say, a species of individuals compared to those going to fertility treatments. They want scheduling. They want control, you see. So to be able to start, you can actually go on to progestin for a while before you then decide to start, right? Am I right to say that?
Yes. So that is a very good point.
Yeah, that being the case, the main message we want to get across to people here is this is a very robust, resilient methodology in so far as giving us as good, at least, success rates in terms of outcomes. And of course, the cost effectiveness point of view is thrown towards us, and they would say, okay, this we save on the antagonist, which is extremely expensive compared to maybe a couple of tablets of Dufaston or Provera. But then one has to argue that this means you have to defer your embryo transfer. This has to be frozen cycles. There's no way you can do a fresh cycle, right? So what is your point of view in terms of that argument about cost containment?
Yes, because as you said that when we apply the PPOS or progestin-primed
Mm-hmm.
ovarian stimulation, we cannot transfer the embryo in the cycle. We must do the frozen cycle and postpone the transfer for at least one cycle. There are advantage or disadvantage in PPOS. The most important advantage of PPOS is the convenience, and it's patient friendly. And as you said
Absolutely.
that the PPOS can also lower the gonadotropin usage.
Mm-hmm.
Usually, when we apply PPOS, the gonadotropin dosage will be lower than when we doing the long agonist cycle. But usually it's equal with antagonist cycle. There are one very important phenomenon is that LH can be suppressed by progestin, but it's not as profound as the long agonist cycle. But it's
Mm-hmm.
above the level of the antagonist cycle.
Yes.
And also, when it comes to PPOS, there are several kinds of progestin. We can use dufaston, or we can use MPA. We can also use like Dinogest
Yes.
to
Yeah.
suppress the endometriosis. And we can also use nature micronized progesterone. Several kinds
Yes.
of different
Yes.
progestin,
Yeah.
but the suppression of the LH is also different.
Yeah. You brought up
Uh,
a really important point, Prof. The fact that we can use Dinoes. You know, we have so many endometriosis sufferers. They have
yes.
finally attained pain control, and yet we
Mhm.
want to do ovarian stimulation. This is our typical scenario in a lot of cases. I've used that a lot in those women who've had, endometriotic cysts, large endometriotic
Yes.
cysts,
Yes.
Dinoges on board, a nice stimulation, getting the eggs, because you and I know that the moment you touch and do any kind of surgery, a massive drop in AMH can occur. So this is a tremendous sort of approach that we had used in the early years because we wanted to manage these patients along with the fact that they had endometriosis. So it's a very important point you have brought up. And the fact that most of the progesterones are fairly similar. You're at liberty. If your country doesn't have Provera, you can use Dufaston.
Mhm.
Polizos recently presented a paper on Utrogestan. These are
Mhm.
all fairly equal in. So the message we want to put across is progesterones can do the job. Okay.
Mhm.
So
Yes.
and let's face it. I mean, in modern day IVF, either for embryo banking or oncofertility or egg freezing, it is more commonplace really to do a freeze all, right? I mean, that's
Yes.
seems to be the norm. And then we choose when to put the embryos in, when we have sort of corrected the womb, the uterine lining, there might be polyps, there might be endometriosis to handle. So actually, this is a very timely intervention. I'm really glad that in the recent 5 years, we've managed to have this concept, and thanks to the Dr. Kwang who first, noticed this. I mean, it is there. Sometimes something is so glaringly there, but it doesn't get into our neuronal working, so to
Mhm.
speak, to translate it into, a valuable clinical practice. So the whole concept of dual stimulation was theirs as well. The Shanghai Protocol, as it was called. And I think it's all nicely marrying together, but we can't forget our antagonists. We still need our antagonists, when we want to
Yes.
do a fresh cycle.
Mm.
What is your experience with the various progestins? Do you find one a little bit better than the others in terms of tolerance of side effects?
I think those progestins generally can do the job, and as they and they are evenly effective, but still some nuance between those different progestins.
Yeah, so it's very personal.
For example,
one question I want to ask you is, what about the, sorry to interrupt, but I just want to cover one more aspect, flexible start, I usually start my progesterones from the day they start the stimulation because, it's hard for them to come back. I can even defer my scan across a weekend and be free to be assured that, LH will not surge and I can still do the scan. But if I'm going to do what's known as a flexible start, like on day 5 or 6, then see whether I want to start the progesterone. What is your take on that?
I think flexible start is also very nice because you can, when you decide that you want to freeze-all of the patient, then you can start with the Progestin-primed ovarian stimulation.
That's right.
But before that, you can still have chance to transfer the embryo freshly.
Precisely.
Yes,
Good
so
point. And
flexible is also very nice.
It makes our decision making more nimble,
Yes.
More nimble. Yes. What are some pearls of wisdom in your experience? You've done so many hundreds of cases of PPOS compared to antagonists. What is the thing that strikes you the most in the outcomes, the patient experience?
Yeah, the most impressed is the cost, because for most of our patients, economical reason or economical issue is also very important.
I see.
And so use this progestin is very cheap and inexpensive and can do the very good job. And so most of our patients would be very welcome this kind of
happy about that. Yes. So, Dr. Ho, I think I might have to round off the session. Thank you so much for sharing your insights into the PPOS protocol and its role in modern-day IVF cycles. Your expertise has provided our listeners with a comprehensive understanding of this innovative approach to ovarian stimulation, which I dare say might take over a good segment of our stimulation patients. And to all our viewers and listeners, thank you for joining this episode of the Aspire Ed Talks. And we hope you found this discussion informative and beneficial. Please feedback to us if you feel that we should have included something different or any additional things that you might have liked to see. Stay tuned for our next episode as well, and to explore the cutting-edge advancements in reproductive medicine. Aspire is an organization that takes to heart the education of all of our members, and this is a serious intervention, or rather project, as it were, that we led by Professor Duru Shah and her entire team. And I hope that you found this podcast valuable and useful. And Professor Jason, thank you so much. Really appreciated all your pearls of wisdom, and thank you for sharing this with us.
Thank you very much. Thank you.